All right. My name's Aaron Dezube. I'm presenting on long-term outcomes following esophagectomy in older and younger adults with esophageal cancer. I thank SAGES for having me. All right. I have no disclosures. So esophageal cancer is primarily a disease of older adults. Even so, older adults are less likely to undergo esophagectomy, and this is multifactorial, from patient preference to physician guidance. And studies examining survival and disease-free survival after esophagectomy remain limited in this patient cohort. Given the extensive morbidity associated with esophagectomy, we need more long-term data as to recommend whether older adults really should undergo the surgery for shared decision-making. So our first aim was to compare long-term outcomes, including overall survival and disease-free survival between older and younger adults. And secondly, to examine the impact of time with improvement in perioperative care and change in neoadjuvant regimens on how this might influence outcomes. So this is a single-center retrospective study of all patients over the age of 18 with esophageal cancer over a 15-year span. We looked at baseline characteristics, perioperative and long-term outcomes, and stratified the analysis between two age groups, those less than 75 and those 75 or older, and then performed a temporal analysis from 2005 to 2012 and 2013 to 2020. This is chosen at the time point of the CROSS trial. Overall, we had 1,135 patients enrolled, the breakdown shown here. The median age was 63. Most patients were male with a good performance status. Overall, most patients did receive neoadjuvant with a limited subset receiving adjuvant therapy. Most cases were adenocarcinoma at the distal esophagus, and R0 resection was achieved in the majority of patients. We found that most cases, surgery was either performed by Ivor Lewis or a modified McEwen technique. So just a brief summary, younger patients had less comorbidity, better performance status with an ECOG score on average of 0 to 1, and received more neoadjuvant than adjuvant, and were more likely to undergo a modified McEwen. Overall surgical approach and tumor staging was otherwise similar. Younger patients did have fewer complications, but when we examined this by grade, this was only significant for grade 2 complications. They did have a shorter length of stay, but only by a net difference of 1 day, although 30-day readmissions were lower and discharge disposition was markedly different between the two age groups. So when we looked at overall survival, as you can see here, median overall survival was different. Younger patients had better overall survival, which is confirmed in our Cox model. When we looked at disease-free survival, and similarly for local, regional, and distant disease-free survival, we actually found no difference between the age groups. And we stratified this a little bit more by both pathologic stage and clinical stage. As shown here is by pathologic stage, and what we found was that this was not consistent across stages. For those who had complete tumor response, we actually found overall survival to be similar between the age groups. Then this seemed to differ. For those with stage 2 disease, we thought the fact that there was no difference was more suggestive of the low event rate in this patient population. So then we looked at 2 time periods, and overall tumors were more advanced. There was a transition to more Ivor Lewis being performed. What we found was age was no longer associated with neoadjuvant rates or surgical technique, and overall in grade 2 complications improved in this cohort. When we looked at disease-free survival and overall survival, what we found was that disease-free survival did not improve over time, nor did overall survival. But when we looked at 2 time periods for overall survival, you can see that at 1 year, survival became similar in the latter time period, and then it diverged after that at 5 years. And this is just to highlight that point, that as you can see from those over the age of 75 and less than 75 from 2013 to 2020, that it really became statistically similar. So again, this is a single center study. All patients were retrospectively identified, and we didn't have measures of frailty. Therefore, we also didn't have competing causes of death. So what we conclude from this is that perioperative outcomes and short-term survival are becoming similar, but long-term survival is still worse in older adults. Given the similar disease-free survival, we suspect this is due to competing causes of death with contributing unmeasured frailty factors, particularly as we saw that in those with complete pathologic response, that's in this small cohort of patients that survival was similar. So the next step is really identifying those who may be at higher risk to better stratify who would be a better candidate for surgery in this older group, as age alone should not limit. Thank you.